this computer? Okay, so we'll start with a case, I guess, and I'll invent a case, and then you guys will tell me what's your differential diagnosis is how you would target this case. Okay, so you have a baby that is born at 37 weeks after a C-section with maternal diabetes, and you're called to the delivery room because the baby has some nasal flaring. So you start CPAP, and then on CPAP, the baby starts behaving better, and his saturation are, in the low 90s, high 80s. And each time you remove the CPAP, the saturations are going a bit down in the 85. But when you put back the CPAP, it seems like the oxygenation gets slightly better, but never dramatically better. So you decide to admit this patient, you call him a TTN, you do an X-ray, there's relatively okay lung expansion. And then, you give a bit of oxygen, and on the oxygen, you start 30, 40%, and the baby's satting like 88, 90. So you wonder if this is respiratory distress syndrome. You look at the X-ray, there's no ground glass appearance. There's relatively good air expansion. The cardiac silhouette looks okay. But the baby, who looks slightly tachypneic, is not dramatically tachypneic. You decide to send a blood gas. You have a CO2 of 38 with a pH of 7.32. So relatively within normal. And so you decide to put the baby on 80% oxygen, and now you're satting 93. Okay, and now you decide to put the baby on 100% oxygen, and the baby is still satting 93. So first of all, is that normal? Is that expected? What is going on in your mind now based on this patient?
Can I have a question?
Yes.
How much the pre and post saturation and blood pressure in this baby?
Very good question. So your pre is like 93, 92, and your post is maybe something like 85, 86. And your blood pressure right now is about 50 on 20 with a mean of, 55 on 25 with a mean of 38. And that's like with a cuff blood pressure, and you've obtained that in the leg.
And how's about the heart rate?
You have a heart rate of 155 to 160, and it fluctuates in time.
So now we have the terms baby that history of the C-section is the low risk for the infection. The mom has a history of the GDM, and they need a higher in the FiO2 with the pre and post differential saturation that is more than 5.
Mm-hmm.
The borderline the blood pressure and normal in the heart rate.
Mm-hmm.
So in this situation, I'm thinking about the pulmonary hypertension or any how's about the lactate in the gas that we
You have a
have?
lactate of 2.53 capillary.
It's unremarkable. That is not too high, but in this GDM that we should be concerning about the heart abnormality like the hypertrophic cardiomyopathy or any congenital heart disease. So
Mm-hmm.
for now, in the saturation, I'm thinking about the pulmonary PPHN or some low cardiac output, even or in the right side or the left side. So
Okay.
before I go start any other medication, I will do the echocardiogram to make sure that my function is good before I will start the INO.
Okay, but your baby is not yet, obviously. Okay, I will just slightly backtrack. Before even thinking of INO, this is a baby on CPAP who doesn't seem to have major respiratory distress, right? So even before giving INO, I would ask myself the question, well, is this like significant PPHN? If so, do I need to intubate? Do I need to mobilize lines? Do I need to attempt surfactant? Is there a risk factor for RDS? We don't think this is RDS. So I would first go back to like these steps, like how's my airway? Do I have secretion? What's my air entry and all these things? And I agree, like this story for me is a huge red flag for there's something else that's happening, in the sense that there might be somewhere right to left shunting at the atrial level, because when I give 100% oxygen, there's just no response. So a few reasons why a baby, you're going to give oxygen and the baby, like let's say you're giving 100% oxygen to a baby and you have normal lungs. If I go in the pulmonary vein and I take a blood gas, what's going to be the saturation of my hemoglobin in this blood gas? I have beautiful lungs. How much saturation of oxygen you should get in your pulmonary vein?
It should be good.
Like how much good? Give a number if you have to guess.
It should be 100.
It should be 100. Unless you have atelectasis or intrapulmonary VQ mismatch or any kind of other reason why blood flow is going to go through the lung and not get oxygenated, your pulmonary venous return should be saturating 100. If it's not saturating 100, if you get a pulmonary venous return at 80 or 85 or 90, because you have intrapulmonary right to left shunting, it's because you have probably something wrong with your lungs, in the sense that your airway could be a problem. You may have atelectasis. You may have lung disease, a pneumonia. You may have diaphragmatic hernia, BPD, CDH, meconium aspiration syndrome, airway disease, plugs, hypoventilation syndrome, neuromuscular diseases, atresia of certain, airways. So that could definitely be a reason why you may have issues with your pulmonary venous return in terms of oxygenation in your pulmonary venous return, and which means that your left atrium, which is the normal area where the pulmonary veins are going to be connecting, will be desaturated. And if that's desaturated, your left ventricular preload will be desaturated, and eventually your left ventricular output will be desaturated, and everything in your aorta will be desaturated. Make sense? So that's one first reason. The fact that you're giving 100% to a baby that is breathing relatively well with no work of breathing, an x-ray that is relatively reassuring, and that you're giving recruitment and you're still not having 100% of saturation, it means somewhere there is right to left shunting. It's highly unlikely that it's intrapulmonary, like the way we describe the case at this point. So yes, I agree with you. I would want to rule out that there's not a right to left shunt somewhere in the heart or extracardiac, like post tricuspid or even ductal, or another lesion that would explain that. So if I would have told you that the right side, the right preductal limb is 80% of saturation, and your postductal limb, sorry, it's 70% of saturation, and your postductal limb is 85 to 90. Laurence?
Yeah, I would think TGA.
Okay, so which type of TGA? We like to be precise in hemodynamics.
Detransposition.
Okay, with which kind of physiology? Any
With
kind of TGA?
No. So with pulmonary hypertension.
Okay, perfect. So that's the first one. What's the second one?
Isn't it like when you have obstruction to the LVO?
So is it LVO?
Maybe not. Right.
Because your LV,
I have to draw
so your
it.
LV and transposition, is connected to what?
Oh no, the opposite, sorry.
So
Yeah.
it would be an obstruct. So, but it wouldn't be. Yes, Leila, it would be likely intact ventricular septum in this case, but it's typically the DTGA or with some degree of high PVR. We call it pulmonary hypertension, but it's a bit of a misnomer.
Mhm.
And then, or DTGA with coarctation, or DTGA with interrupted aortic arch. These are the three more classic. There is one other that we will talk today, but these are the three classic. So if we go into, let me see if I can show you this. I think I can show you this. No, it's not working from my computer because I am, let me open my Zoom from another place. Okay, open Zoom. Join. Perfect. Can you still hear me?
Yes.
Fantastic. So now I'm going to share my screen. And we're going to go here. And we are going to go under here and DTGA. And then here we will open a beautiful presentation that was previously prepared for us, so it's easier to show. So, okay, we know that in DTGA, typically your aorta and your pulmonary artery are transposed, which means that the aorta is coming out from the morphological RV and the pulmonary artery is connected to the morphological left ventricle. Does that make sense to all of you? Which means that LV, who's receiving oxygenated blood flow, will pump to the pulmonary artery. So the LVO is actually leading to the pulmonary artery. And if you can sometimes have, there are situations like, for example, double outlet right ventricle with transposition of great artery. We call this the Blalock-Taussig malformation. And many of these patients may have some degree of outflow tract obstruction, and it might be confusing because if the cardiologist tells you in fetal life there's LV outflow tract obstruction, it means that it's the pulmonary side that is obstructed, the pulmonary artery side that is obstructed. So you have to be aware of what is the cardiologist telling you when they're assessing these patients, right? Because they're transposed. And so I find this diagram, and if you don't have it, the Rudolph, I find it's a very important textbook to have. It's on the password protected portal under fellowship resources and under textbooks, or it's also at the McGill Library online. So what happens is you get blue blood coming back for your right atrium from the systemic venous return. This blue goes to the RV. This RV pumps into your aorta, okay? Now, if your PVR are very low compared to your SVR, then the blue blood will be able to be shunted from the left side to the right side or from the aorta to the pulmonary via the duct. And so you get blue blood re-entering your pulmonary vasculature via the PDA. But if you follow the duct, there's really no oxygen that is able to enter the descending aorta through this ductus arteriosus. Make sense? Because in life, everything is a matter of ratio of resistance and pressures, okay? So if you have two structures that are connected by a big duct, okay, the resistance will drive the flow. So if your PVR are very low and your SVR are very high, you get the flow from the aorta to the pulmonary. So there's no red blood being able to eject from the LV and entering the aorta. The only place you're able to bring oxygen into the systemic compartment and into your brain is via this tiny little communication that we call the foraminal valley, okay, which will typically shunt bidirectional in these patients because you're in the early life and because the RV and LV at this point have relatively similar end diastolic pressure just in the immediate postnatal life. Now, just so you are aware, so two questions. My first question, okay, I'll go backtrack. Sorry, I go all over the place. In fetal life, that's a question for Piscini or Laurence. In fetal life, what is higher in terms of pressure? The pulmonary artery pressure or the aortic pressure?
It's going to be the pulmonary artery pressure in the fetal life that most of the blood will go through the ductus arteriosus, that more than 2/3 pass through from to the aorta.
Okay, I will ask again the question. Okay, I'll repeat first I'll ask another question to make you think. What drives the pressure? What generates the pressure?
Flow and resistance.
Flow and resistance. Perfect. Let's ask ourselves again the question. In fetal life, the pulmonary artery and the aorta, are they typically standing on their own or are they connected by something? Do you have a connection between your aorta and your pulmonary artery in fetal life? Aorta and then pulmonary artery? Do you have a connection between the two? You do?
Yeah.
Okay. If you take a box and you fill it with a pressure, and then you take another box and you connect the two boxes. If your pressure in box number 1 is 100 millimeters of mercury, what is going to be the pressure in box number 2?
The same
It's going to be
pressure.
the same. I'm going to re-ask my question.
Yeah. The
In
resistance. That's
fetal
different.
life, what is the higher pressure, the pulmonary artery or the aorta?
The same.
It's the same. It's a trick question. So if you have the same pulmonary arterial pressure, then the aorta, because the two are connected, by definition, you're isosystemic. And that's a very important concept to keep in mind even after birth. When your duct is large and you connect the two systems, by definition, pressures will always be isosystemic because your duct does not restrict pressure transmission if it's very, very large. Okay. Now, you may have some flow and pressure attenuation along the walls. But if your duct is the size of the aorta, you're going to have the same pressure or very rapid equalization of pressure. And what will drive your flow will be the resistance gradient. Okay? So in fetal life, you're right to say that the pulmonary vascular resistance is extremely high and your systemic vascular resistance is extremely low. You have a huge PDA. The pressure in your pulmonary vasculature is the same than the pressure in the aorta, which is likely something like a mean of, 18 or 20. It's very low generally, but that is sufficient to drive forward the blood flow. And what drives the flow from the pulmonary artery to the aorta is obviously the ratio between the PVR and the SVR. So a large volume of blood coming out of your pulmonary artery will be redirected into your aortic flow because there's typically oxygen in that and because you don't need to send too much blood flow to your lungs. So that's the first concept that's very important to kind of anchor is the relationship of pressure. So each time you do a little diagram, so I'm going to show the diagram again. You go in TNE protocol. Where's protocol? Protocol, Novology. Am I crazy? Oh, it's here. Then TNE protocol. Each time you take a patient and you're trying to understand the patient, you take the graph and you put your pressures everywhere. So if I know that this pressure is 80 on 60 and I have a huge PDA, by definition, my PA pressure will be 80 on 60. But if I know the direction of the duct, whether in systole and diastole, then I'm able to deduct what's the ratio of the SVR and PVR in each part of the cardiac cycle. So it gives you indirect information on that. So it's important to keep in mind these concepts because the concepts in fetal life will be applied in postnatal life. Okay, I will go back to here. So why do we put PGE in these patients if the duct is not going to serve to promote oxygenation to the system? What's the reasoning of putting PGE? Why are we putting something to increase pulmonary blood flow when this channel does not allow you for mixing? And that's true also for a VSD, by the way, because VSD, the pulmonary valve and the aortic valve will open in systole and blood flow will be generated in the aortic compartment and pulmonary compartment during systole by the underlying ventricles. And if you have a hole in between, in systole, typically your RV, because RV is facing the aorta, the flow will go from right to left. So you get blue entering your LV. So it's not a channel that allows you for the LV to decompress into the RV because RV is facing a higher resistance profile than your LV that is facing a lower resistance profile typically. So in that sense, most commonly VSDs will go from the right to the left if you have higher SVR than PVR. And so VSDs are not great to allow sufficient mixing unless it's like a huge VSD that is almost like taking the entire septum. But most of the time, they're not that big. And so that's why you can never rely on a VSD. And if there's one key message, every single TGA, VSD or no VSD, intact septum or not intact septum, you should think that this patient will need an urgent septostomy at birth, regardless if there's a VSD or not. If you try to like reassure yourself that there's a VSD and you don't prepare for septostomy, you're going to get fooled and you're really, really going to get in trouble. So never rely on the presence of a VSD and TGA to think that these channels will allow sufficient mixing, okay? The only channel that typically allows sufficient mixing is the interatrial shunt. Why is that? So sorry, why is it that we then keep PGEs to keep the PDA open in this disease when you know that you're not going to mix by the PDA? What's the rationale? Pessini or Laurence?
Because it is another way to connect between the two sides or the parallel circulation.
No, but it's not because of that. It's not because it allows mixing. The PDA doesn't allow mixing in TGA. That's not why we keep it open.
Is it to buy time before the septostomy, like just for the correct surgical correction, like to improve the oxygen saturation or something like that?
Not necessarily. If your PVR have already dropped, only if your PVR are high, we'll get to that. But your PVR, if they're not high, it's not gonna help mixing. What happens?
It's gonna give the blood flow to the lungs.
And what happens with this pulmonary blood flow to the lungs? Why is it good to have a lot of pulmonary blood flow to the lungs?
Just allowing some oxygenated blood to the systemic circulation, probably.
Okay.
Like I think about the PDA, it could be right to left chanting or left to right chanting, mostly left to right chanting at the level of the PDA, but I don't know.
So when you open your PDA, you're going to promote increased pulmonary blood flow. So let's say that your PVR are indeed lower than your SVR. The directionality here will be from the aorta to the pulmonary vascular bed. So your pulmonary vasculature will get slightly increased pulmonary blood flow compared to what it's supposed to see. We call this increased QPQS. Your ratio of pulmonary blood flow to systemic blood flow will rise, will be more than 1. Typically, the pulmonary blood flow and the systemic blood flow are the same. They're matched, right? If you have increased pulmonary blood flow, what's going to happen to your left atrium? Think of your preemies that you have big duct. What happens to the left atrium?
It's larger.
It increases, right? You get more preload.
And so give the blood go through the shunt between interatrial shunt.
That is the reason. That is the reason. So the preload of the left ventricle, okay, is in a normal heart solely dictated by the amount of blood flow coming back from the lungs, or by right to left shunting at the atrial level, if you have nothing coming back from your lungs. So the left ventricle and left ventricular output depends on the left atrial filling, and the left atrial filling depends on what's coming back from the lungs. So when you bolus a patient 1, 2, 3 times, what you're increasing is the preload coming back to the right atrium, which eventually goes to the right ventricle, which you hope will go through the lungs and then increase the preload in your left atrium. That's if you don't have like a massive pulmonary hemorrhages emptying into the lungs, or that is if you're not, backspacing everything in your tissues, like for example, your soft tissues or your liver because your RV is failing, for example. So you have to be very careful when administering fluid bolus because it has to do this entire track before getting to your left atrium. And that's why when you assess preload, we often look, yes, at the IVC and SVC when they're relatively not on high mean airway pressure on the ventilator, but it's not sufficient because your left atrial preload is really dependent on what's happening at the level of the lungs. Okay, and we can talk a bit more about that on other cases. But for example, if your LA is underfilled, your LV is underfilled, and you have a big duct, sometimes the output of the LV is so bad because of that your PDA starts shunting right to left because it's filling the aorta because there's nothing coming out of your LV. Okay, We sometimes see that with pulmonary hemorrhages where suddenly their PDA becomes right to left. And part of the reason is because the LA is underfilled, the LV is underfilled, and they have less output, and they then become dependent on this RV to provide output to the systemic vasculature. And sometimes it's also because they get reactive vasoconstriction in their pulmonary vascular bed, which will increase PVR. So it depends on the situation. Now, going back to this particular question I was asking, the reason why you give PGE is that it's increasing pulmonary blood flow, increasing pulmonary venous return, increases your left atrial filling, and the LA pressure will rise, which allows your LA to have a higher pressure than your right atrium and promotes blood flow from left to right at this level. So this is the place where you're going to send oxygen to your pulmonary, to your systemic vasculature. And that's how you're going to promote that as you're trying to increase this interatrial communication. So that's one of the reasons. The second reason is this. In fetal life, it's quite difficult in babies with TGA to actually detect if there is a frank coarctation because they have a big duct open, and a lot of the ductal tissue can sometimes cover the aortic rim at the isthmus level and create something that we call a posterior shelf. And the tissue around this posterior shelf is actually similar to ductal tissue, and as the duct closes, the coarctation happens. Okay. In French, we call it un éperon postérieur, if you guys are looking for the name in French. And so what does this do is that there are two situations or three situations where you can have these reverse differential saturation with a TGA. It's either in a situation of coarctation, interrupted aortic arch, or what we call pulmonary hypertension. Okay. Pulmonary hypertension is a bit of a misnomer. Why I say it's a misnomer is because when we say hypertension, it means high blood pressure. But we just said that the pressure in the lungs, if you have a big PDA, will be the same as your systemic pressure, which is high for a lung. You're not supposed to have your systemic pressures in your lungs. But really, when you talk about pulmonary hypertension or PPHN, it's really trying to translate that you have high pulmonary vascular resistances or higher than expected pulmonary vascular resistances, in the sense that your PVR are higher than what it would be expected for the age and the transitional process. Does that make sense? Yeah?
Yep.
Okay. So here, if we follow this diagram, this time you see you have blood flow coming back from your lungs, entering your left atrium. This is oxygenated, going to your LV, going to your pulmonary artery. But because your PVR are much higher than your SVR, okay, forget there's a coarct. Imagine there's no coarct. If your PVR are much higher than your SVR, then obviously the balanced PVR, SVR are going to drive right to left shunting at the level of the descending aorta. And that's why you get these differential saturations. That's why they get, 65, 65 and then 85 in the postductal limbs. Now, to have this setup is not necessarily desirable in the sense that having PPHN or acute PH or high PVR is not necessarily good. It means your baby is not transitioning well. It means that the baby's living a stress. It's typically these babies that are born that have already a degree of asphyxia, acidosis, stress, hypoxia. So we will see these patients that are critical have these reverse differential saturation. And although it allows for some shunting at the level of the PDA to provide a bit of mixing or oxygen to this descending aorta, this is not necessarily a desirable state. It means that whatever you're doing, you're not acting fast enough to actually generate enough mixing and avoid hypoxia of tissue. Because often it's because these patients are already acidotic with low pH, and that's why they vasoconstrict or poorly transition their lungs. Okay, so these are particularly the babies that I'm the most concerned about when I see these reverse differential. Second reason why they have these reverse differential is if you have a coarct or interrupted aortic arch, and now your PDA is essential for a right to left shunting. We have a patient in the unit right now who had a posterior shelf on the aorta, and on fetal echo, they couldn't see that there was a coarct. So that's the second reason why you start PGE, because 10% of TGA will have some degree of aortic arch obstruction. Okay. Now, if you have a complete aortic valvular stenosis, okay, you're not going to see reverse differential of SAT. What's going to happen is that your PDA is going to feed retrograde your aorta and anterograde your aorta, and your SATs will be the same everywhere. So that's why, Laurence, when you said LV obstruction, which I knew you meant RV obstruction, but aortic valve stenosis, they don't have these reverse differential of SAT unless you have some degree of forward flow. But if you're at the point of having an obstruction that is significant, creating a critical obstruction, then you would just have retrograde flow here and all your SATs would be the same everywhere. Okay, so we spoke about the setup of TGA with reverse differential of SAT, but we'll go back to our baby because it's 135. And we were saying this patient has reversal of SATs, okay? I'm telling you, there is reversal of SATs. But when you give oxygen, okay, you get to like the 92, 95%. And if I do an echo, I tell you, oh, this kid doesn't have TGA. There's something else, but he doesn't have TGA. What could this patient have that is not TGA and that will cause reverse differential of SAT? It's the other disease that is very rare that could cause.
Interrupted aortic arch.
No, typically interrupted aortic arch with normal ventricular configuration will have pre and post differential SATs, but they won't have reverse differential SATs. So it's the kind of things that if you don't know, you won't figure out on your own. So it's a supracardiac total pulmonary venous return, and it's because of the streaming of blood flow. So the reason why is that typically what they have in these supracardiac TAPVR or TAPVC is that blood flow comes back from the pulmonary veins, very well saturated, typically will enter a vertical vein into the innominate vein, and generally will drain into a right SVC. Because the SVC faces the tricuspid valve, this is the blood that's been very well saturated. So you see 90%, and this is 60%, okay? This 90% will have a tendency to actually enter through your SVC and then eventually shunt into your right ventricle because it's facing the tricuspid valve. So it's like pouring from on top into the right ventricle directly, like the stream of blood flow is going down into the right ventricle. Right ventricle, you see, saturates at 88, enters the pulmonary artery at 88%, and then feeds the pulmonary artery at 88%, okay? And then if there was a PDA, okay, typically the streaming coming back from the IVC will enter more through your PFO into your right atrium, into your left atrium. So now maybe you mixed along the way, so you're not 60, but you're like 70. Okay, forget the 88 here. 70, 70, and then enters your ascending aorta at 70. Does that make sense up to now? If you have a duct and for some reason your PVR are higher than your SVR, beginning of life, for example, or you start having obstruction of your pulmonary vein for some reason, which is very unlikely with this conformation because typically supracardiac won't obstruct it, but it could. It could obstruct. It's not guaranteed that it doesn't. It's typically the infradiaphragmatic that obstructs, but you could still have obstruction of the confluence of the vertical vein, okay, because they're abnormally shaped. So as your PVR drop and you get more blood flow through this structure that is abnormally shaped, it's not able to accommodate this flow. Because what happens in fetal life is that you grow because you stimulate growth by flow. But because the PVR are low, there's not much flow in the pulmonary vasculature. So then there's not much flow through the pulmonary vein. So whatever collects into this collector that we call a vertical vein may be growing to accommodate this very low pulmonary blood flow. But when you are born and your PVR are dropping and your pulmonary blood flow rises, suddenly you have more pulmonary blood flow and more pulmonary venous return, and maybe this collector won't be able to accommodate. Okay. So what I'm saying is that some of these patients may have increased PVR or may have some degree of post-capillary pulmonary hypertension at some point or a blockage, which will increase backup pressure into the pulmonary arteries, which eventually may surpass what's happening on the systemic side. And so at this point, if you have a duct that's still open, your blood flow will become right to left, and this blood flow is more oxygenated than here. I just told you this was 70 and this is 88. Does that make sense? That's the other very rare occasion where you can have a reverse differential of saturation. It's extremely rare. Personally, I've seen a few supracardiac TAPVR going through a vertical vein, but I've never seen them shunt right to left and then lead to a differential saturation, but it's been described. So just so you're aware of this condition. Okay. Now, what's the diagnostic key of a TAPVR? There is one finding on echo that should prompt you to always say, okay, I need to rule out TAPVR. What is the one finding if you do a TNE and you see that you should always rule out a TAPVR? It's kind of like, guess.
The flow across the PFO
Yes. How would it be, the flow across the PFO?
is right to left.
It's a strict, it's not almost, it's only right to left. There is no left to right because there's nothing coming back to your left atrium. So the left atrium is completely empty and its preload only depends on the right to left shunt at the atrial level. So we call it an obligatory right to left shunting at the atrial level. And when you see a right to left shunt at the atrial level, which is rare in newborns to have a strict right to left shunt at the atrial level, you always, always, always need to rule out TAPVR. What are other causes of right to left shunt at the atrial level? I want to hear at least 7.
Vein of Galen.
Perfect. So the vein of Galen depends on the size of it and the volume of it, right? So a very massive vein of Galen that will overflood and create a massive left to right shunt at the level of the head and bring your blood flow to your SVC and overwhelm the SVC and eventually overwhelms your right atrium to the point that it's just not able to empty in the right ventricle because there's just so much flow coming back, will empty to the left atrium by creating a right to left shunt. Absolutely. What else? So number 1, number 2.
And the right ventricle diastolic dysfunction.
Severe RV dysfunction. Okay. So for example, patients who have Noonan syndrome may have significant RV remodeling. They may have significant RV hypertrophy. And this RV hypertrophy may be causing a significant right to left shunt at the atrial level. Perfect. What else? What could happen to the tricuspid valve?
Tricuspid atresia.
Tricuspid atresia, right? There's nothing else where it can go. So it has to be a right to left shunting at the atrial level. What else?
Or pulmonary atresia, the same.
So if you have pulmonary atresia with an intact ventricular septum,
okay,
and then the RV is not able to unload anywhere, obviously everything is going to go back and back up into the right atrium and it's going to shunt right to left. So pulmonary atresia, intact ventricular septum. If you have a critical pulmonary stenosis or pulmonary atresia with a VSD, and this VSD is extremely restrictive, which is rare, but it could happen, your RV pressure may become very high. You may get RV and diastolic high pressure, which will transmit to your right atrium when the tricuspid valve opens. And because of that, you may also have a right to left shunt at the atrial level, right? Because the tricuspid valve open in diastole and the RA pressure is then connected to the RV and you get equalization of pressure. So if you have a high diastolic RV pressure, you're going to have a high RA pressure as well, right? Because they're going to be the same. They're connected. So rule number 1, 2 boxes that are connected, they always have the same pressure. Rule number 2, resistance will drive the direction of the flow. Perfect. Then what else? So we said tricuspid atresia, pulmonary, RV outflow tract obstruction with RV and diastolic failure. We spoke about vein of Galen malformation. What else?
Is it in a critical aortic stenosis sometimes if the LA pressure is so high, we can have...
so typically in critical aortic stenosis, your LV is struggling because your LV is struggling, you get high LV pressure at the end of diastole because it's not able to empty. And because of that, you get a backflow into your left atrium. And because you get a backflow into the left atrium, you have high LA pressure. Because you have high LA pressure, if there's an ASD, typically it will decompress into your right atrium. So it's a left to right shunt. If there's no ASD, it will back up into the lungs and you get a pulmonary edema.
So it's sometimes it can go right to left through the PFO if there is an ASD. That's what you're saying.
There is the shunt is going to be right to left at the ASD level if the right-sided pressure is higher than the left-sided pressure. Because the atriums are low pressure chambers, and it's really the pressure that drives the flow across the foraminal valley or the ASD. So RA pressure will increase if there's too much flow coming to the right atrium. So too much flow coming back to the right atrium. Vein of Galen, hepatic arteriovenous malformation, total anomalous pulmonary venous return. These are the typically 3 big categories of why you have too much flow. Or it could be because there's too much pressure into the right atrium. And that's because, for example, there's a tricuspid atresia. There's an Epstein anomaly with too much backflow into your right atrium. There is RV diastolic dysfunction, and that could be either typically because the RV is facing too much afterload. So what could be the reason why the RV is facing too much afterload? Either there's too much high PVR and then the PDA is closing. And so then the pressure into the pulmonary artery starts rising because it's not able to equalize with the aortic pressure because the PDA is closing. So then you have very high PA pressure. As the RV is compensating by still maintaining output, eventually the RV starts failing and the RV end diastolic pressure becomes very, very high. And you can get right to left shunting at your atrial level. So in acute pulmonary hypertension, where there's very high PVR, your ARV and diastolic pressure may rise, and you may also have a right to left shunt at your atrial level. But typically, most kids with acute PH or PPHN, they have bidirectional PFOs with a larger component of right to left compared to left to right. Does that make sense? The other reason why in PPHN there's right to left shunting at the atrial level is that there's less pulmonary blood flow. So your LA filling is going to drop. And because your LA filling is dropping, your LA pressure is dropping compared to the RA pressure. Okay?
Yeah.
So if you see a strict right to left shunt at the atrial level, these are the kind of things you need to rule out. Do I have a tricuspid valve? Is my tricuspid valve working? Do I have a right ventricle? Is my right ventricular working? What's happening to my RVOT? Do I have a pulmonary valve opening and closing? Do I have pulmonary blood flow? What's happening to my duct? And then you absolutely need to make sure, well, what's happening to my pulmonary veins? Are they draining the right side? Okay. And then you start thinking about these kind of rarer things, you know, hepatic AVM. So then you put your probe on the liver just to make sure you're not missing something there. You put the probe on the head to make sure you're not missing a big, you know, vascular malformation. You look at your SVC, you look at your IVC to see the flow. You look at your aortic flow to see is there retrograde flow somewhere. But the first thing is ruling out TAPVR when you see a right to left shunting. Who's going from our team? You, me, and Gil. Jared asked me to present PS highlights. I will also not be here, I think. Okay, we have 12 minutes, so I just want to share again.
Yep, I have a question.
Yes,
for the
me.
TAPUR is for the all type. I mean, that should have the right to left shunt.
All of them.
All type.
If you have total anomalous pulmonary venous return, it means that your veins are always coming together into the right atrium. It means you never have anything in your left atrium. It's very, very, very different than a partial anomalous pulmonary venous return. These are completely 2 different diseases. A PAPVR is like an ASD. It's a left to right shunt because you have filling in your left atrium. So you have like 2 or 3 veins coming back to your left atrium, but then you have 1 vein that goes into your right atrium and overwhelms your right atrium and overwhelms your right ventricle with too much flow. So with time, when they're becoming older, they start having these pneumonia, you know, failure to thrive, always exhausted, tachypnea, all these things. Okay, and eventually they can even develop Eisenmenger when they're in their 40s. So they act as an ASD. But the TAPVR will always be a strict right to left shunting. And the most common areas where you're going to have TAPVR is typically the TAPVR that's classic, that's coming back. So you have your pulmonary veins coming back via vertical vein into the innominate vein and eventually draining into your right-sided SVC. Or you can have a total pulmonary venous return coming back to the coronary sinus, which becomes very enlarged. Okay. These are rarely obstructed. The one that you dread the most is this one, what we call the infradiaphragmatic one. Why? Is that typically the collector is draining in something called the ductus venosus that I'm sure you heard about. The ductus venosus is a structure that usually helps your umbilical vein connect to your IVC via some of the portal veins. Okay. And the problem with this ductus venosus is that it's designed to close as soon as possible after birth. And that's why in term babies, it's hard to get UVL central because this ductus, the mechanism to close the ductus venosus are very mature. And it's the thing you want to close as early as possible because you don't want the baby, you don't want to empty your blood into the environment when you cut your cord. Right? That's why the ductus venosus clamps. Okay. The problem is as it clamps, then suddenly, and that's why there's an arrow, you get almost no blood flow coming back into your IVC, and then you get backup pressure in your pulmonary venous bed. And because you get backup pressure, you eventually get backup pressure into your lungs, and your lungs become with very, very high intravascular distending pressure. And then, you get leakage and you get pulmonary edema. And eventually this patient actually gets very low preload because, everything that's coming back is backing up into your pulmonary artery. Then your RV pressure and diastolic pressure rises. So then your RA more and more, instead of going into your right ventricle, will shunt everything into the left atrium because the left atrium and left ventricle are completely empty. So your baby becomes bluer and bluer and bluer and eventually codes because there's no output. So that's the kid you're very worried about. These are emergency situations where you need to bring the kid to the operating room to correct the defect as soon as possible. If you have this that is non-obstructed or this that is non-obstructed, it's not as much of an emergency. You'll need to bring to the OR in neonatal life, but you don't need to run to the OR at 3 a.m. This, there's not much you can do. There's no medical therapies you can really do. If your kid is stuck 7 hours up north in a flight that needs to come here, you can start PGE, and what it will do in some patient is that you hope it will open the ductus venosus and relieve some of the obstruction. There are case reports described as such, but it could also worsen your situation by maintaining a duct wide open, decreasing your PVR, and then promoting more blood flow going to your pulmonary vasculature and then the pulmonary vasculature that's obstructed. So that's why people have a tendency to be extremely worried to start PG in these patients. Although if your kid is dying 6 hours away, that's one thing that you should be considering. There's case reports to try to at least open your ductus venosus because it does respond to some degree to the prostaglandin, the same way the ductus arteriosus responds to the prostaglandin. But it's an obligatory right to left shunting. And if you do the OSCE stations that is on the website that Syria is going through, there is one station hidden somewhere that has a TAPVR. Okay, 153. Any questions?
And back to the case, any progression from your case?
This case, you do the echo and you find that there is indeed a supradiaphragmatic TAPVR non-obstructed with strict right to left shunting. And that's why the baby's having some reverse differential of SAT. And so you call cardiology, your surgeon, and everyone comes and they're very happy to come at 3 a.m. to do management evaluation. Typically also in these patients, they'll ask also a CT angio because it's harder to get a full picture of the collectors and to understand. You don't want to miss two collectors, and then you tell your surgeon, or there's only one collector that you need to kind of re-roof and unroof and put back into the left atrium. So they want to make sure that, you know, all the pulmonary veins are draining to the same place and that they are not missing any of the pulmonary veins. And then they would need to go back into a chest that they operated that is very, very hard because there's a lot of scarring and they've missed, and then it becomes a partial pulmonary venous return that they're going to have to go back after. So that's why sometimes you need to do CT angio to get just like a full picture of the anatomy and not missing any of the collectors.
Any other side? Oh, sorry.
And then they typically also do what we call a sutureless repair, which means that they'll never suture the actual ostium. They'll suture like they do kind of a sleeve, and they suture like kind of on the side to make sure that the entire opening of the ostium is kind of like curled like this. So it helps to avoid secondary stenosis because it's one of the complications that could happen. Sutureless repair pulmonary veins. Yeah, there's nice little drawings on Google that you can see that they do this sutureless repair to avoid having a suture line at the ostium. Okay, 156.
Any other signs in the echo that we are should thinking more than the obligated right to left shunt that we should thinking about the TAPVR?
If you see a very, very large coronary sinus, that's something you need to rule out. Two things that you need to think if you see a very large coronary sinus is number one, it could be a TAPVR coming back to your coronary sinus. Number two, it could be a left SVC coming back to the coronary sinus. And number three, it could be because you have very, very high right atrial pressure. So then you need to understand why there's high right atrial pressure, because the coronary sinus typically drains in your right atrium. So you need to make sure you know, you're not missing something that is causing a very high right atrial pressure. Okay, I have another meeting starting, but I hope this was useful.